right, thank you very much. Thank you to all of you for coming, and thank you to the organizers for giving me the opportunity to speak about this very interesting disease. There we go. So I'll start with a case. This young lady came to me earlier at the beginning of the summer. She's a 15-year-old girl who'd complained about abdominal pain and back pain for 4 years. She was otherwise a very high-achieving young lady, got good grades, and was very active in sports. She went to her primary care doctor one day for vomiting and pain that was more severe than usual. She'd never had any imaging performed up until that point. So her primary care doctor got a KUB, which revealed bilateral kidney stones, and blood work revealed a BUN of 64 and a creatinine of 7.15, much to their surprise. So she was referred to the local hospital for management by an adult urologist. There, a CT scan revealed bilateral hydronephrosis as well as bilateral stones, right worse than left. These are just two slices from the CT scan just to show the significant stone burden on the right, along with an atrophic, smaller right kidney compared to the left, but also a few scattered stones in the left as well. So the urologist placed stents bilaterally and said, this is too hot for me, and referred her over to a local pediatric ICU where she stayed for 5 days, and her BUN and creatinine slowly improved simply by putting in the stents. And she was discharged with a creatinine of 1.08, which is of course not normal, but near normal. So her parents arranged for a consultation at the Mayo Clinic, given how severe the case was. So we also had her see some of our pediatric urologists, and because of the significant stone burden and the minimal function of the right kidney that was seen on functional imaging, she had a right-sided nephrectomy. So this is pretty, you can imagine the parents' reaction when we said, okay, we have to take out one of your otherwise seemingly healthy 15-year-old girl's kidneys. So fortunately, we were able to analyze the stone material that came out with that kidney, and you're not surprised that it was 100% cysteine because you're sitting in a talk about cysteinuria, but we were a bit surprised. So when I talked to the parents about the diagnosis and told them their daughter had cysteinuria, of course their first question was, what is cysteinuria? So cysteinuria is a rare autosomal recessive genetic kidney stone disease. It can also be categorized as an inborn error of metabolism, and it's the most common form of monogenic stone disease. At the Rare Kidney Stone Consortium that is housed at the Mayo Clinic, we traditionally and historically have treated 4 monogenic kidney stone diseases, including primary hyperoxaluria, dent disease, APRT deficiency, and cysteinuria. We are, as we're learning more about genetics and of course understanding the complexity, we are expanding that list of diseases. But cysteinuria is one of our old favorites. So it comes from an inability to reabsorb the filtered dibasic amino acids, including cysteine, ornithine, lysine, and arginine in the proximal tubule. The lack of ability to reabsorb the ornithine, lysine, and arginine are not clinically significant, but of course the cysteine leads to crystals and stones. So we know about 2 main genetic defects that lead to cysteinuria. So there's the SLC7A9. The SLC stands for solute carrier 7A9, which encodes for this amino acid transporter that transports both neutral and positive amino acids. It's been given this cumbersome notation that I'm not even really sure how to pronounce, but we'll refer to it as the amino acid transporter. Then the SLC3A1 encodes for the protein known as RBAT, which stands for related to that amino acid transporter. Clever nomenclature. So So the amino acid transporter is the conduit for getting the cysteine from the urinary space into the epithelial cells, and the RBAT is what traffics that transporter to the apical membrane. So in cartoon form, you've got the luminal side here in the proximal tubule, and then these are the two proteins we're interested in. Here is the actual amino acid transporter that takes cysteine into the cell, and then the RBAT is coupled with it and helps traffic it to the apical membrane. So when you have cysteinuria, you have a defect in these one or both of these proteins, and therefore the cysteine stays out in the lumen. You get a high cysteine concentration that leads to crystallization and ultimately stones. Here are the associated genes with each of the proteins. So when we talk about the mechanism of injury to the kidneys in stone diseases, of course we've known for a long time that when you get large obstructive stones, you get obstructive uropathy, the same as you do in anatomically obstructive processes. But we're also learning more about the nature of crystal nephropathy, other ways besides obstruction in which crystals cause kidney disease, chronic kidney disease, and decline in GFR. So this is a nice review from Nature Reviews Nephrology that came out this year that talks about crystal nephropathy in general, but cysteine is included in that discussion. So you can see highlighted in red in this nice cartoon where cysteine can accumulate and cause trouble in the medullary thick ascending limb as well as the collecting duct. But then also, interestingly, you can get cysteine accumulation in the parenchyma, in the cortex, as well as the papilla. And so as this accumulates in the renal parenchyma, you get first accumulation here in the lumen, and then you get a sort of urothelialization, if you will, where the urothelial cells sort of form a wall over that accumulation of crystals, and these are taken up into the parenchyma. And that causes an inflammatory process that ultimately leads to granuloma formation and fibrosis and scarring. So fibrosed and scarred kidney tissue is non-functioning kidney tissue. You get enough of it, your GFR goes down, and that's how you get, that's the mechanism of CKD. So in order to land up in that position, you have to have a urinary environment that's conducive to cysteine crystal and stone formation. So that includes high concentration of insoluble cysteine, right? When the dimer, cysteine, is insoluble, whereas cysteine is more soluble, and a low urinary pH. So it's like uric acid stones, the pH is very important in cysteinuria. So the way we treat cysteinuria traditionally is by modifying the urinary environment to reduce solubility. So one way we do that is we can alkalinize the urine. We use potassium citrate to increase the urine pH to a goal of at least 7.0. The textbooks and guidelines and things like that say 7.0. Personally, I really try to aim for 7.5. It's usually achievable in compliant patients and really just decreases the solubility that much further. You can also alkalinize or cause more alkaline urine by limiting animal protein, because the ingestion of animal protein leads to a more acidic urine. Then we can talk about ways to reduce the concentration of cysteine. So again, limiting the intake of animal protein is important, as that's an upstream source for cysteine. So in kids, of course, it can be a little bit complicated, and because they're growing, right? So we don't want to restrict their protein too much. we don't know what the right answer is. We don't know how much you can restrict protein without affecting growth and development. So generally, I will recommend a normal amount of protein. In other words, avoiding excessive protein. Sometimes you get pushback if you've got a 16-year-old boy who's trying to bulk up and make the varsity football team, and he's doing it by taking protein supplements and eating, 20 ounces of steak a day. So those are the kids where we have to reel them back in a bit. And of course, the hallmark is to increasing solubility is to increase their water intake. For adults, we aim for 4 liters a day, and the smaller the child, the lower that number goes. But it's always a lot of water. I would say our patients with primary hyperoxaluria and cysteinuria are the ones who have the highest burden of water intake. And I want to take a moment just to point out something very interesting we learned in our stone patients. This was specifically from patients with primary hyperoxaluria, but we had a very nice presentation done by a 13-year-old boy and his 15-year-old sister. The study they performed all on their own, where they did sort of quality of life studies on primary hyperoxaluria. And what we learned from these kids and adolescents was that when we looked at all the things that bothered them about having this severe stone-forming disease, their kidney stones, that wasn't number one on their list. The number one problem for them was all the water they had to drink. That was sort of surprising to us, because we thought, well, if you're drinking enough water that you're not forming stones, you must be happy. But it turns out it was actually, they were like, you know what, I would actually be fine with a stone now and again if I just didn't have to drink all this water every single day. So just keep that in mind when you're talking to your patients, and it's easy to judge them for complaining about having to drink water, right? All right, so talking more about the modifiable risk factors. So there's medication that we can use, right? So again, with the goal of, we want to minimize this insoluble cysteine and keep things in the more soluble cysteine formation. So there's the older D-penicillamine and the more recent alpha-mercaptopropiononyl glycine, also known as tiopronin. And so what that does is it breaks this apart, and you get a complex of cysteine with the drug that is soluble. Okay, so we use Thiola. We like to achieve, if we can achieve optimal goals with just water and potassium citrate and limiting protein, that's great. For a lot of patients, you also need the tiopronin to get them where you want them, which brings us to how do we know that they are where we want them to be. So I always judge my success as a kidney stone doctor with 2 main parameters. One is stone burden seen on imaging, and second is the frequency or severity of clinical episodes. Okay, so we use ultrasound usually to monitor these patients, and we monitor the number of stones and the size of their stones. If their stone burden is increasing, I'm not doing my job. If it's staying the same or possibly getting better, then I feel good about myself. And of course, if they're not ending up in the emergency room with clinically evident stone episodes, then that's good too. So then on a more nuanced level, we follow 24-hour urine cysteine supersaturation and capacity. So supersaturation and capacity are sort of 2 sides of the same coin. Capacity, and so that's a concept and an assay that was generated by our friends at Litholink to help better monitor risk for cysteine stones, because it's a little more complicated with cysteine. So the bottom line, when you're looking at cysteine capacity, if you're using the Litholink assay, you want a positive number. That's good. So when you get your report back, you'll get either a positive number or a negative number. And so ultimately you want, they have a goal of greater than 150 to prevent formation of cysteine stones. So one way to say it is that a supersaturated urine will lose cysteine into this solid cysteine mass, giving it a negative value, whereas an undersaturated urine will take up cysteine, giving it a positive value. So if you have a urine that has a positive capacity, that means if you put more cysteine into the urine, that's okay. It can accept it and not form stones. It's, again, the semantics are complicated, but fortunately, the reports that you get when you measure this in a 24-hour urine explain it very nicely. And this is just a cartoon depiction of supersaturation again to show you that if you have an undersaturated solution that you add crystals to, those crystals will dissolve. If you have a supersaturated solution and you add crystals, you will form more crystals and bigger crystals. Then, of course, most importantly, it's important to continue to follow GFR, right? That's ultimately what we care about. So we know with cysteinuria that there is a high rate of CKD. One study shows that 77% of patients with cysteinuria have some degree of CKD, and 27% have a GFR of less than 60. Looking at this in graph form, so you see this sort of a bell curve of you have GFR on the x-axis, number of patients on the y-axis. Most patients fell into a sort of moderate degree of CKD. In this pie chart, the 23% represented those with a GFR of greater than 90. The vast majority have some degree of CKD. In this study, few people ended up requiring a kidney transplant, but it does happen. Then finally, this is our own data from the Rare Kidney Stone Consortium, where we compare the slope of the decline of GFR. In the red dashed line is historical controls. The blue line is patients with cysteinuria, and you can see they have a steeper slope of decline. So that's the information I have for you, and we are going to hopefully have some time for questions for both cysteinuria and cystinosis at the end, but for people who have specific questions about cysteinuria, I think I will defer to my fearless leader, but I think we have time for a couple of questions. So thank you very much for your attention.
So we do have time for a couple of questions for Dr. Sass. David, I'll ask one question. So your slide on GFR, so a substantial percentage of these patients have CKD. Is it due to, you think, late diagnosis, or what do you think has precipitated such a high prevalence of CKD in this group?
Well, I think so. The disease, as stone diseases go, cysteinuria is severe, right? So they have more stones and bigger stones and get bigger stones faster than other stone diseases. And so I think just the accumulation of stones, despite our best efforts to treat, is probably the main reason. But they also often are diagnosed late. You know, it's a shame that we don't get stones more analyzed more frequently, more commonly, because that does make the diagnosis in this particular disease.
Great. Question?
Hello. Thank you for the talk. Can you comment on the efficacy, if any, of captopril in this disease?
So, yeah, the captopril has traditionally is included in the drugs that may affect solubility of cysteine. And it can be used, but there was a nice study published a few years ago that showed that it does decrease or increase solubility, but just very little. So it's not part of my treatment plan generally. It can be useful, but it's minimal compared to tiopronin.
Which lab do you prefer for measuring 24-hour urine cysteine? We are told it should be mass spec, and Littlelink doesn't use mass spec.
So while we run generally we run our 24-hour urines in-house at the Mayo Clinic, but for cysteine specifically, we use Littlelink because of that capacity assay.
Does tiopronin interfere there? We are told that the level will overread when they are on tiopronin.
Well, and so so that's their assay is sort of built to correct for that.
Yes, to alkalinize the urine, we have experience in using acetazolamide on top of potassium citrate to lower the number of pills to be taken.
I have not used acetazolamide. Generally, we're able to get it done with potassium citrate if they're willing to take it. But that seems like a viable option also.
And also, some patients develop a nephrotic syndrome with the D-penicillamine, and then we have to use Thiola. In Canada, the price of Thiola has went up quite high, so it's almost none available because of this. I don't know here in the States if you came across the same problem with the price of this drug.
Yeah, so I haven't had a problem getting it for my patients because if their insurance doesn't cover it, we can often, first of all, convince the insurance companies to cover it when we say, hey, if we don't get this, we're headed towards dialysis and a kidney transplant, and that's more expensive. But they also, the drug company also offers some discounts where you fill out paperwork and register the patient with them, and they find a way to get them the drug. So bottom line is I have not, it's a barrier, but not an overwhelming barrier for us to get them treatment.
Okay, 2 more questions.
Thank you. Nice talk. A comment and a question. I have used captopril over the years, but you know, you have to give a very high dose. If you look at the molecular weight, is even higher than penicillamine, so you may have to give more than 200-300 milligrams to achieve the same binding. So you may as well add another penicillamine pill to the dose. And the question is, the production of stones in patients over the years is highly unpredictable sometimes. Some of them start forming stones in their 40s, and some of them go through periods of stone formation, which is unrelated to treatment. Any thoughts there? Why?
Well, so it's a complicated mixture of genes, which we're learning are more complicated than we thought, and their environment. And I'm a big believer that stones can form very quickly, and if they have one bad day of fluid intake, they can form crystals in stones just like that. But one of the things that we're doing to address that through the Rare Kidney Stone Consortium, we're starting a research protocol where we have developed a panel of 90 different genes associated with stone formation, and we're going to be testing patients on a research basis to look specifically for not just monogenic stone disease, but also potential disease modifiers. Why do some people with the exact same gene mutation, don't present till they're 40, and some present in infancy? So that's one of the things we're going to continue looking at, because it is one of the challenges, that it's very variable.
Thank you.
Just one last question.
Excellent talk. Just had a question about the redox part of the thiols. Any work with N-acetylcysteine as far as keeping the thiol groups from oxidizing and forming the dimers?
Right, so I haven't heard of that. The latest thing, the big paper that came out in Nature Genetics was the alpha-lipoic acid, which there is no established mechanism for how that works, but the theory is that it works as an antioxidant, and so that's in the works. That line of thinking is being studied now, but there's I don't think any great data to support its use just yet.
And for the supersaturation that you talked about up there, are they controlling for temperature, or is that the 24-hour where you check for if it precipitates or not?
So you're asking, does Litholink control for the temperature?
Correct.
I believe so. I have to be honest, I don't know specifically what temperature they keep it at the different phases of the assay, but they're pretty smart people over there. I would bet yes, but I don't know for sure. I'd have to ask them. Sure.
Okay, thanks, David.
Okay.
Thank you very much.